Okay, everyone, thanks for coming. We're really excited to have all you guys on to talk all things kind of basketball today. We're really excited to have some guests. Just a couple of housekeeping announcements. This is going to be recorded for just the sake of the best audio. If everyone can kind of keep their microphones on mute unless they have comments or questions that they're looking to ask. So without further ado, we'll kind of get started here. So we have two awesome experts on the call. I'm really excited to have everyone here today. The first is Carlos Bustamante, an old friend of mine and now an assistant athletic trainer with the Washington Wizards. Former Badger, excited to have you back. Carlos, you just want to introduce yourself and kind of tell us where you're at?
Yeah, hi everyone. My name is Carlos Bustamante. Like Bailey said, I'm an athletic trainer with the Washington Wizards. I'm originally from Los Angeles, California. Made my way to Wisconsin. After Wisconsin, made a pit stop in Georgia to get my master's at Georgia State/Georgia Tech. And after finishing my time there, I've moved over to the Washington Wizards. So I've been there since 2017, and so I work all things athletic training and and then some. So. I'm just really happy to be here.
Awesome. Really excited to have you and really looking forward to learning from you as well. And then our other expert we have on the call today is Ryan Brooks. Ryan's currently working as a physical therapist for the Hawks. Ryan, do you want to tell us a little bit about what you're up to and anything you want to say?
Yeah, for sure. Thank you for having me. First and foremost, I did all my education at UNC Chapel Hill, and then after that, ended up going to University of Miami for residency, and Duke for a fellowship, all in sports PT, and then I went to Rutgers University as a director of rehab and football. So it's only with the football team there. And then I spent my first season with the Atlanta Hawks. This past season, always wanted to get back towards basketball. Didn't think it would be as fast as it was. But no complaints here. I love working with these guys, so it's been really good.
Awesome. Definitely miss having you in the Big Ten, but excited that you ended up where you want to be. And then moving right along here, we also have three reviewers with some different basketball experience on the call. For those of you who have not had the pleasure of meeting, my name is Bailey. I work as a PT for all the different sports at Badger Athletics, including men's and women's basketball. So I'm really excited to talk about those things today and about my personal favorite sport. We also have Cassidy on the call. Cassidy, do you want to introduce yourself?
Yeah, I'm Cassidy Papa. I'm currently a physical therapist with the Charlotte Hornets. I had a similar kind of route, I guess, to Ryan in terms of PT school and then residency, and then I did the Wake Forest Division One Sports Fellowship 2 years ago, and I'm about to enter my second season with the Hornets.
Awesome. Congrats. That is great. And then finally, we also have Tim Eshelman on the call. Tim, do you want to tell us where you're at as well?
Yep. Hey everyone, Tim. I'm the current D1 fellow at University of Pittsburgh. Similar kind of journey as Cassie and Ryan. I went to PT school, residency, and then now I'm in fellowship. Fun fact, I was a PT student at Miami when Ryan was a resident, so we go way back.
Nice. Awesome. We got a couple of former classmates, I suppose you would say, on the call, which is great. So really excited to dive into this. Upcoming events we have coming. We do have our next journal club is clinical implications for baseball athletes. So if you're interested in that, feel free to mark down that date. And then as always, we know there's a lot of experiences both in the chat and people on the call. So if you do have any comments, questions, things like that, please feel free to either raise your hand or put it in the chat and we'll be monitoring that. But definitely want to acknowledge the experience of our audience as well. So without further ado, we're going to get rolling here, and I'm going to throw this to Tim to talk to us a little bit about preseason screening for patellar tendonitis.
Cool. So the article I reviewed was preseason patellar tendon thickness predicts symptomatic patellar tendinopathy in male NCAA Division I basketball players. The purpose of this study is kind of in the title. They wanted to determine if increased preseason proximal patellar tendon thickness predicts symptomatic patellar tendinopathy during NCAA basketball season. The study was a cohort study of 27 participants, all of whom were male NCAA Division I basketball players at either Columbia or Fordham University, with a mean age of 20.7 years. The primary assessments they completed in this were patella tendon anterior posterior thickness and hyperechoic regions, which were assessed via ultrasound with the Butterfly IQ Plus portable ultrasound device. Prior to reading this, I actually hadn't heard of the device, but I looked it up and it's pretty cool. It's a portable ultrasound device that you can actually plug into your smartphone, and you can use your smartphone as a screen. Similar to, hopefully you can see that little GIF on the right side. This was serendipitous, but I happen to have this video on my phone of one of our sports med physicians here doing an ultrasound on one of our athletes. And so it might look similar to, the study might have looked similar to that. In addition to looking at thickness and hypoechoic regions, that should say, they looked at, they palpated for patella tendon tenderness and also looked at, had the athletes complete a Victoria Institute of Sport Assessment patella tendon score or VISA-P score. So the outcomes they tracked throughout the season were a trip to training room for symptoms, which they categorized as a TTR. They also looked at time loss symptomatic patella tendinopathy, which they categorized as TLPT, which is anything involving one or more missed games. They also looked at hypoechoic regions and tendon ruptures. And so the data they collected was completed at 3 different time points: preseason, midseason, and postseason. And all of the athletes at the preseason completed their assessments within 5 days of their first game. So what did they find? The mean preseason patella tendon thickness was 4.78 millimeters. And of all the tendons involved, 9 required a trip to training room and 4 developed symptomatic or time loss symptomatic patella tendinopathy at some point during the season. And luckily there were no tendon ruptures. And then now we can kind of get into the interesting findings. Was that they found that for each 1 milliliter increase in preseason patella tendon thickness, there was a 3.6 times higher odds of a trip to training room at some point during the basketball season. And when they looked at 2 different categories of thicknesses, when the tendon thickness was 8 millimeters or greater, this led to an 86% predicted probability of a trip to the training room, while a preseason tendon thickness of 4 millimeters or less was associated with a 3.4% predicted probability of the trip to the training room. So you can see the huge difference there as far as tendon thickness and predicted probability of symptomatic symptoms. So what does this mean for us clinically? So obviously this is a perfect world scenario where the athletes have access to not only an ultrasound, but a clinician who can utilize and interpret the ultrasound. So if we're in a setting where we can utilize ultrasound, we can potentially use it in our preseason screening to kind of help bucket athletes in a high-risk category for symptomatic patella tendinopathy, particularly if their thickness is 8 millimeters or greater. And as far as prevention, these high-risk bucket athletes might be kind of triaged towards physical therapy, where we can include interventions and different activity modifications. I won't dive deeper into this, as Bailey has a great article she's going to evaluate next. And then as far as policy, this study does support integrating ultrasound into preseason physicals for elite jumping athletes. And then do we move on to straight on to our discussion questions, Bailey?
Yep, you're good to go.
Yep. Oh, okay. So we have a couple of discussion questions for Carlos and Ryan, one of which was, should preseason ultrasound be a standard part of clearance exams for basketball players?
I guess I'll start. And I think, it's not an easy answer, I would say. I think we're still learning a bunch about how it can be used. And I think the data is promising, but I think when you're talking about clearance, I think it's a multifactorial, decision. There's a lot that goes into, why the athlete might be experiencing what they're experiencing. And I think there's, a battery of things that you'll have at your disposal to kind of see, all right, where are they and how can we use all this information to determine if they're, ready to play. So I think based on everything included in the article, I think the data is very promising. I think, I guess without, diving too far into or too deep into the under our hood of, kind of our processes, it's definitely something that's, being considered or talked about more frequently and even within our group. But again, it's still, I think, very, very new, just accessibility wise. So I think, Tim, you mentioned that, somebody would have to be essentially know what they're doing. So like you'd have to have someone who's responsible for essentially being skilled and trained and reading these and looking to see that they're, you know, seeing what they're supposed to be seeing. So I think it's very promising, and I think it's something that can help us out in the future. So yeah.
Yeah, and I would kind of piggyback off of that. I agree wholeheartedly. Don't necessarily think it should be like, you know, to clear someone. But it's definitely, it can add useful information. I mean, these guys are pretty inundated, like especially if you have someone who's new with, you know, there's a ton of imaging that happens already. And if someone's been with the team for a long time, you most likely know, like if they've had like patellar tendon issues in the past, or even if you're getting someone from a different team, you know, sort of if they've had patellar tendon issues. So you would do like a prehab, if you want to use that word, type program with them. Anyway, I think where this fits in is for tracking purposes, like maybe showing the athlete improvement, or showing the athlete maybe that it's getting a little thicker and a little worse, or even showing them, you know, that it's something they're feeling correlates, or what you're seeing on the image correlates with what they're feeling. I think that's kind of where the advantage of this tool comes into play. It is pretty specialized though. You have to have someone, at least the way we do it, we have one person on staff who, you know, knows how to do it really well, and they kind of handle it to keep some of the reliability where it needs to be between people.
Cool.
I completely agree on both of those fronts. One of the things I agree with both you guys on that I think is interesting that we've seen kind of at Wisconsin is we have like one postdoc student who's like, or postdoc who's extremely good at patellar like tendon ultrasound, right? He's been doing it, it's all his research, anything. So I feel like very confident about him being able to do it and like use it that way. But like me doing it, completely different story, right? Like I don't trust myself doing it. I don't trust, like it just takes so many like scans to get that point. So that's something that I thought was interesting. Like if you have the resources and have someone who's awesome at it, it's probably helpful. But it just is like so new to Carlos's point too, that it's like you take so much to get that good at it. So I think that's interesting. And then I think both you guys kind of touched on this. The hesitation that I have with this aspect of it, as well as like if the person is asymptomatic, which may not happen as much in these high level teams that you guys are working with, but do we want to like kind of put that in someone's head or start like talking through it, all of a sudden they have this extra image on them and like how that plays in as well. So I think the messaging is pretty important too with it, but just two different things that kind of came up when I was reading through this one too.
Yeah, kind of just building off that point kind of leads into my next question was, how should clinicians manage asymptomatic athletes with 8 millimeters or greater of tendon thickness? Because maybe they're asymptomatic, but then also if we go out looking for something, we'll probably find something. So then how do we use that data if that's the case?
I think, you know, similarly to kind of what we said, or what Bailey said, it's all about how you message it to the athlete. And as the article pointed out, like, you know, it gets a little worse over the season anyway. So it is asymptomatic now, but it's going to potentially increase in thickness over the course of the season, especially if this person's dealt with it before in the past and it's a known recurring problem. I think in finding ways to kind of almost microdose it like within what they're doing, whether it's, you know, their pre-practice stuff, doing isometrics, or maybe it's at the end of their lift doing like, you know, 2 extra sets or 3 extra sets of one specific exercise. And that can be an isometric, but finding ways to get it into what they do on a daily basis, whether it's a practice day or recovery day or game day, and make it something that's easy and manageable so that it's not adding a ton of their schedule. And so it's easily completable, and just be proactive and stay on top of it.
Yeah, and I guess piggybacking off of what Ryan mentioned before, like it's, you know, one piece of the puzzle. So I think it's giving us information we're tracking over time. And I think we'll have, pretty much a profile of what these players have dealt with in the past. So I think it could be a little tricky if we, solely rely on, hey, like the ultrasound is saying you have 8 millimeter thickness and this is the data that's associated with it. Like, I think depending on who the player is, like it could work out and it could also kind of backfire. So I think it's something to kind of keep in mind with the rest of, the battery of test screens to kind of be like, okay, is this someone who is known to have a history of patellar tendon, along the course of the season? Are we tracking this? Like Ryan said, this typically does get thicker throughout the season anyway. So I think, what is their kind of baseline? Where do they live and where do they tend to get symptomatic would be something to kind of keep track of over the course of the season. Not just say that, okay, 8 millimeters is, pretty much the catch-all for everybody.
Thank you. That kind of leads into the next question I had. As you kind of alluded, this is the piece of the puzzle. What other objective measures do you guys think would be useful in like the preseason screen to kind of assess risk?
Yeah, I think really anything that's like, again, completing a picture of the athlete, how they move, maybe a movement screen. Really, the more objective data that you can get, so you can paint a picture of the baseline measures, really before the season, because that's when you're typically collecting all these measures. Range of motion, dynamometry, force plate testing, et cetera. So like you're using it all to kind of, again, paint a picture, and you're not using one test per se. You're kind of, when the time comes, let's see how this is trending. Yeah, that's how I would say.
Yeah, I agree. Whether, like Carlos said, some sort of movement assessment, some sort of strength proxy, whether that's handheld dynamometry or like an isokinetic dynamometry, getting some strength values for the knees and being able to compare it side to side. And then more dynamic tests, so like counter movement jump, drop jump. I think collecting, and then on top of that, even collecting like their past injury history and availability. How many games have they missed, year to year because of this condition? That's something easy and simple you can, use to kind of, I guess, get rapport with them. Like, hey, look, you missed 15 games last year with this. Like 15 games is a decent chunk of the season. We want to make sure we do X, Y, and Z to try and mitigate that going forward. So I know that's not like an objective test per se, but it gives you, I guess, something to use with the athlete.
Just out of personal curiosity, you guys, do you have set like days throughout the season or off season where like the whole team does some sort of objective like assessment, like whatever we're gonna do, force plate jumps this many times, like at this week of the season or whatever, to track it proactively across the team? Or are you guys more within the individual, just monitoring as you go through the process?
I'd say the way we do things, it's a little more individualized. There are some like initiatives that have started with like the NBA biomechanics group, that where there's something team wide that they're measuring from a biomechanical standpoint with like cameras, force plates, certain movements and jumps. But we like to do, for the most part, things very like on an individual basis. And
Sure.
we'll just set that, within like whoever's working with the player, staying on top of, we have to assess X, Y, and Z at this certain interval, and just because especially within the season, how chaotic it is, you might not, you might say we're going to do this every 4 weeks, but then that fourth week you're on the road for a week. So then it becomes, the fifth week because it's hard to do on the road. So.
Yeah, that totally
Yeah.
makes sense too.
Yeah, a little bit of both.
Yeah. Awesome. All right, we're going to keep rolling for the sake of time onto our next study here. So now, as Tim alluded to, we're going to talk a little bit more about the treatment of tendons. I picked this article because I think it's such an infuriating, but also so interesting of an injury, and like how each clinician programs, I think is interesting. And I just think it's something we don't entirely have figured out from a sports medicine perspective. So this is an article that came out of the British Journal of Sports Medicine in 2021. And it basically challenged the idea of doing like heavy eccentrics for these patients versus like a progressive tendon loading protocol, basically. And they had a total of 76 patients, and it could be anyone from a recreational athlete all the way up to a professional athlete. The main thing or inclusion criteria is that they had to participate in their sport 3 times a week. There was way more males than females, 58 males, 18 males, or sorry, 58 males, 18 females in this group, and the ages were between 18 and 35, and they had to have some sort of diagnosis of patellar tendinopathy. It could be anywhere between 6 months worth of symptoms all the way up to 2+ years, basically. And there was some stratification that was performed to try to even out the groups depending on the people who had a shorter time frame versus a longer time frame when it came to their symptoms. And then there were, as you guys I'm sure are aware, many athletes who have bilateral symptoms. And so for the sake of this study, they were just asked to rate their most painful leg, but they did the exercises on both sides. And then another thing that I think highlights how difficult this condition was is that 82% of the people that they enrolled in this study had previously failed conservative treatment for this injury, right? So they've already gone through this battery of like rehab, and at least to what they consider like an acceptable outcome, they haven't hit it yet. So I just think it highlights the difficulty that goes with this. So there were 2 main groups. The first was what we're going to call the experimental group, which is the progressive tendon loading. And in this group, there was 2 main differences. The first is that their acceptable pain while they were doing the exercise had to be a 3 out of 10 or lower. So a little bit lower than what we see in kind of the traditional heavy eccentric literature out there. And then in this group, there was a series of 4 stages. So they had isometric exercises, then they would lead into isotonics, then into plyometrics, and then into their sport-specific rehab. Whereas in this more control group, which is the eccentric exercise therapy, the pain level was allowed to be higher, up to a 5 out of 10, and they only had these 2 levels, which were eccentric exercises and then basically like working on going back to sport. So that's how the 2 groups were split up. What I think's important to note with this is that this was not like supervised physical therapy or supervised athletic training as far as the rehab itself. They were given education and demo and all of this information on the exercises, but then they were doing it on their own at home using this pain monitoring model to kind of guide their progression back and forth. And then another thing that I didn't put on here, both groups also got flexibility training and hip strength and just generalized injury prevention that they did as a part of this, but both groups also got that. One of the things that I'm going to keep bringing up with the study that I think it makes it less applicable to like the college and professional sports world is that these athletes were asked to either completely discontinue or significantly reduce their sports participation until their pain levels fell within the normal range. And I think in the world of pro and college sports, like this is really hard to do, right? You can't completely just cut someone from doing all activity. That's not going to make the player happy. It's not going to make the coaches happy. It's just not really possible all the time. So I do think it's a big limitation of the study, but nonetheless, I think it's interesting to still look at the results with this. So in order to guide the exercise rehab progression, what they did was this daily pain provocation test. So basically they did this single leg squat. So they went down as low as they could on one leg and then they stood up on 2. And they had the patient rate this on a scale of 0 to 10. Obviously 0 being no pain at all, 10 being get made to the hospital. So at this point, each day the athlete would do this and then they would progress their exercises based on their response to this one activity. So to give you an idea of the exercises that were included, on the left here is your eccentric exercise therapy. So they just did this single leg decline squat. And the reps and sets across the weeks and everything is available in the appendix. There was like very specific progressions based on what numbers they hit and how many weeks they were. And then they added resistance to the same exercise as the progression. I think this is a pretty typical one that we see historically for patellar tendonitis. And then based on the sport, they were giving sport-specific exercises before they went back to sport. So again, this was just based on their pain scores and things along those lines as they progressed. In this other group is the progressive tendon loading. It went through this very linear stage of rehab intervention. So they started with isometrics and the sets were up to 45 seconds long. And they gave a couple different options. They had leg press in there, they had knee extension isometrics. And then for those who didn't have access to like weight room or things like that, they did wall sits and things along those lines. So again, I encourage you to look at the appendix if you want to see all the options out there, but it was pretty well laid out from that standpoint. And then when the athletes were able to do this exercise with pain less than a 3 out of 10 and had completed them for a week, they went into isotonic exercises. So again, there were a few new ones, but then there were also just isotonic movements that they did in the isometric phase. And then once that was below 3 out of 10, they went to plyometric energy storage exercises and then sport specific after that. So a much more like linear, first you do this, then you do that type of progression, but made it all the way through. And I should note when it comes to the results for this, they had two main tracking points. The first one was at 12 weeks, and then the second one was at 24 weeks. And then they had the baseline, obviously, at week 0 as well. And there was really 4 different outcomes that they looked at in these athletes. The first was the VISA-P, which Tim already alluded to, which is just a patient-reported functional scale. The next was return to sport, and they did break this down into a lot of different categories. The first just being, did they return to sport at all? And then there was 4 different levels all the way up to what I included here, which was, did you return to sport at your pre-injury level? So that would be like, do you feel like you're back to your healthy self, right? So that was another component of this. And then there was patient satisfaction, which I think is really interesting, in addition to exercise adherence as well. So those were our 4 main outcomes, and the results were a bit surprising to me. The one that had the greatest statistical significant difference between the groups was the VISA-P. So for this functional scale, just in case you weren't familiar, because I couldn't remember, the MCID or clinical difference for this scale was 13 points. And there was a significant improvement in function by the progressive tendon group compared to the eccentric exercise group. And this was the only one where there's a statistically significant difference between the two groups. And what I think is important to like see here is both groups got better, right? And fairly significantly so, but there was a trend and a significance towards that progressive tendon loaded group for the VISA-P at least. As far as return to sport at a pre-injury level, there was no difference between the two groups at either 12 weeks or 24 weeks. But again, what I want to highlight is our return to pre-injury level sport percentages are really low. So for the progressive tendon loading, at 12 weeks, 21% had returned, and at 24 weeks, 43%. And that's not even, we're not even getting to half, right? And then in this eccentric exercise group, at 12 weeks, 7% had returned, at 24, 27%, right? So I think it just highlights the difficulty again of this. The piece that I found interesting, this patient satisfaction piece, I have a really hard time getting guys to do heavy eccentrics, especially in season, depending on where they're at. But this study found that there was really no significant difference between groups as far as patient satisfaction goes. It was pretty similar across both at 12 weeks and at 24 weeks. Now, I think this could be because this wasn't completed in season when they're playing, right? But I think also kind of interesting to consider. And then as far as exercise adherence, they scored that as the percent of the exercise sessions that they documented that they completed. And there was no significant difference between those and the eccentric or versus the progressive tendon loading. So I think my main clinical takeaways here is like, on a more positive note, it appears that both groups did get better across a variety of things. I think the thing that's a little bit more tricky is that our return to pre-injury levels are still pretty low, even with getting 24 weeks of this rehab through this process. But one of my main takeaways is if your athlete that you're working with really prefers one method or the other, or believes in one more than the other, then maybe it's okay for them to do that, right? It seems like there's benefits from both. And I like to kind of give the athletes a little bit of opinion, I suppose, in their rehab to like if they believe in one or over the other. So I thought it was interesting. I think it would be interesting to see how this would play in season. I don't know if that would be something that we could ever get really approved based on some of the results from the eccentric training, but interesting to consider. So I guess we'll start with Carlos and then we'll go to Ryan. In your athletes who have like ongoing patellar tendinopathy in season, what is your guys' initial approach? Do you lean more into one style or the other? or does this change, I guess, if the athlete's in or out of season?
Yeah, I'll start it off. Yeah, I think it depends. Well, like the first thing that we have to consider is like, modifying the symptoms. Like, can we get this person out of pain? Can we reduce the pain? And Bailey, like you mentioned, it's super tough during the season because you don't get to just say, hey, you're not gonna, do anything. And so there's a fine balance of trying to figure out how much time do we have to maybe actually, rest, and then what does this look like to gradually progress the athlete. And I would say it probably looks more like the progressive tendon loading, just because, like, to me, that process, I think, mimics more of like what they're going to do on the court. Like the eccentric training, like I think it all has a place for sure. And like you said, like maybe some prefer one way over the other, but I feel like if you can get their plan to be as close as, whatever their plan A, this is how they play. Like normally that's their plan A. However, you can get that as close as you can to that, then I think we're going to be on the same page on a lot of things. They're going to, buy in a little bit better. And when you were talking about like maybe the adherence to it, especially when it becomes like loading it heavy, like when it becomes something that it's like kind of free or already integrated into some of their training that's already happening anyway, when it doesn't look so much like, I guess, rehab, and it's kind of integrated in essentially the treatment weight room continuum, like I think there's a lot of overlap there. And I think when it's the progressive tendon loading, I think it, like I said, it mimics more of what they're going to be doing on the court anyway. So I think the buy-in is there. And this is during the season. Off season, you may have a little bit more wiggle room because there's not the pressure of the games. But it, even then, there's still, again, that stigma of like, well, the player's not going to want to rest that long either. So I mean, we know that tendons respond to load. So the rest piece, like if we can modify some of those contributing factors as far as their maybe the stuff that's happening on the court or the extra stuff, and then maybe we can get them to a point where they're not as symptomatic, and then we can start doing the things that we know are going to help the athlete out.
Yeah, I agree 100% with what Carlos said. I think in season it's really hard. Well, really what you're trying to do, you're just trying to find ways to modify their load. Obviously, when something like initially happens, I probably lean more towards that progressive tendon loading framework, starting with isometrics. And even, I'm huge when it comes to like isometrics. I mean, me and our strength staff, we break things down from, not just boring isometrics, but like yielding, overcoming, and when is it best to do those, and which one is best for like tendons. We found more success with some of the holding stuff, which that makes sense if you look at like the force velocity profile, where if you have someone doing like an overcoming isometric, they can push theoretically, more than the amount of force that you can obtain during like a concentric contraction. Was that isometric contraction, you get more force. So sometimes starting out with like a holding or yielding isometric is a safer place. So we kind of break that first stage up into two stages where we do holding isometrics first, then we progress towards overcoming or pushing isometrics, and then reintroducing isotonic loading, and that might have modifications as well. So like limiting depth to not like 90 degrees, for example, to minimize tendon compression, or even maybe we're doing more things bilaterally than unilaterally or split stance. And then obviously once you get into like the energy storage phase, I'd say more than us giving them more plyometrics to do their sport, they cover a ton of plyometrics every single time they're on the court. So more of that is maybe monitoring how many jumps they have, how many hard decelerations they have, things like that. but all that to say, in season, it's more so just about modifying what you can, and as Carlos said, trying to get them out of pain initially and modify or modulate pain, whether that's, BFR or maybe it's needling, maybe it's with shockwave, things like that. And then out of season, if they're still with us in market, we can be a little more aggressive. We obviously build a big foundation with things like isometrics and things where they're using tempo on lifts, and then we can really get into, say, things like eccentric training and kind of build muscle volume and kind of build up a base for once the season starts, and just try and maintain that once it starts.
Yeah, I think that building back up in the off season is huge too. Couple of follow-up questions for you guys. Ryan, can you expand a little bit more on the holding versus overcoming isometric? I'm not super familiar with that. Like, what does that look like for you guys, I guess, functionally with an exercise too?
Yeah, and I will say I'm no expert either. Alex Natero's a great person of reference if anyone is interested. He can speak on it way more, um, in a more articulated manner than me. But the way we use it is, we kind of start them off with just holding isometrics because, as I said, it's a little lower intensity wise. So that might be something like just a split stance hold, or we have a Kaiser knee extension. So just having them hold something that's like not a max intent kind of
Yeah.
kick out. And the way like Alex Natera would explain it, that's the holding isometrics are more like tissue um, tissue involved. So you get more tissue adaptation from that. And from the holding, we usually do like 30 to 45 seconds. You're looking for that kind of stress relaxation in the tendon, and then, kind of hitting those other parts of the tendon that may be degenerative or in disrepair. And then for the overcoming isometrics, it's really something we use more so, I would say, beforehand, because they're shorter holds.
Okay.
It's more of a max effort push into something, like you're trying to move a rack or move a weight with maximal intent. So we usually keep that between 4 and 6 seconds, and it's more neurological. It's more priming because it is, in theory, that amount of force you're applying is close to a maximal force. So it's more neurological in nature. And that's why we kind of save that. We start with holding and then move to the pushing. I don't know if that provides enough.
Yeah, no, that's cool. I had never heard it explained that way, so I think that makes a lot of sense. One being more neuro and one being more tissue adaptation too. So that's
Yeah.
cool. With both of this for both Carlos and Ryan, you guys, what pain level, I guess it's all subjective, right? But like what pain level are you cool with or like prescribing per se when these athletes are doing it? And then you touched a little bit on it, but like when do you guys like to, Carlos, I know you said like with the strength staff too, but is there times post practice? Like what do you guys like to do from that perspective?
Yeah, as far as just on a pain scale, I think something around what the progressive tendon loading was, like 3, 4, I think is generally okay as long as it's not getting any worse, especially as like they're going through their exercises. And again, kind of subjective too, because maybe for one player that might be more than another. So just getting to know the player and seeing what kind of works best for them. But yeah, there'll definitely be times where it's, I guess, treatment, I guess, specific and not so much kind of a shared space where, yeah, initially they might start off with us, and it probably is a little bit of both. They're starting off with us so that we're kind of priming everything, addressing any sort of I don't know, soft tissue needs, kind of like Ryan was saying, something to kind of just reduce some of the symptoms so that we can get them to a place where they can at least work through some of the discomfort, or maybe even not have discomfort. But the important thing is we want them to actually do the work that we know is going to help change the tissue. So a little bit of both, yeah.
Got you. Okay, it looks like we have a question from the chat. Matthew, go ahead. I don't know if I have to do anything here. Oh, sorry. Hang on. My bad. Matthew, if you got it, I think you can go. Okay. We'll keep rolling. Matthew, if you have a question, please feel free to raise your hand again too. I might have messed that up. Sorry. All right. We'll keep rolling here and then I'll have a little bit of time, hopefully at the end. We're going to switch gears a little here and then go on to jumping mechanics. So Cassidy, whenever you're ready. Oh, sorry. Whenever you're ready, go ahead.
Yeah, we're gonna zoom out for a second away from the patella tendon. So apologies for anyone that was really keen on diving in a little bit more. So my article was the impact of fatigue on the jumping mechanics and injury risk of basketball players. A little bit of background, per the article was that their theory was that fatigue could impact movement patterns, which could then potentially increase risk of injury or impair performance. There is some research that says that fatigue has been shown to alter basketball players' jumping mechanics, and can lead to kind of changes in kinetics, kinematics, decreased jump height. A lot of different things have been found. And then also things like coordination, timing, and reaction speeds, which in theory, all of them could impact injury risk, but also performance. So kind of their purpose was to examine how fatigue affects basketball players' biomechanics, performance, and risk of harm while jumping is the goal, was the goal of this research. It evaluates the risk of the lower back, knees, and ankle issues and emphasizes how lower back fatigue impacts the jumping mechanism. So what they did was they had 415 male collegiate basketball players divided into 3 age groups. They tracked their jump shot, their CMJ, and then they are they in terms of movements, but then in terms of measurements, they looked at field goal percentage, the CMJ lowest point, which sounds like it's a counter movement depth, but then when you actually read into the article, it's actually just their lowest jump height. So just a little bit of an odd way of explaining that. Their takeoff and landing and EMG of certain muscles. They also had this ankle pain measure, but they kind of didn't talk about it after very much. So I also didn't talk about it very much. And JA stands for joint angles. So results in terms of fatigue, and the impact of it, they saw that field goal percentage decreased, jump height decreased, and then joint angles for the knee, hip, and ankle also decreased, but muscle activity did increase. And then that was specifically like rectus femoris, the spine erectors, and calves, hamstrings, and glutes. And then in terms of injury risk, it was most associated with the changes in field goal percentage, the center of mass displacement, and knee, ankle, and hip joint angles. Um, so this chart basically just shows, again, kind of pre and post fatigue measurements for each of the things that they were looking at. Again, there is no sign of ankle pain scale on here. So again, that's why I did not include it. But you can see that there were somewhat of differences across the board in the pre and post fatigue state for pretty much everything that they measured. But in terms of kind of clinical significance, they found that fatigue does have change or does influence some changes in jumping mechanics in college basketball players. In theory, it impairs performance and shooting accuracy, and also movement mechanics in terms of joint angles and muscle activity. So in theory, fatigue could increase injury risk by lowering jump height, decreasing shot accuracy, and compromising the joint angles. Some limitations of the study were it doesn't provide detail on the fatigue simulation, so we have no idea what the protocol was for what fatigue even meant in this study. It only looked at jumping, and that's not really the only potential risky movement or performance indicator in basketball. If anything, basketball's a lot of submax jumping, so I would argue that it's not the most risk factor. Maybe cumulative jumping is, but not necessarily one-off jumping. So we're probably not capturing the full impact of fatigue and injury risk. It's males only and it's college level only. So in terms of applying it to a setting where there's 3 games a week, 4 games a week, like there is in professional versus 1 to 2 in college, it might not transfer very well, and then have different landing mechanics just from a genetic component sometimes. So applying it to females might not be the most accurate assessment. So overall, just some questions for our experts here. Given the inherent fatigue of an NBA season, what training strategies do you guys implement to help prepare the athletes for the rigor of the season? That's my first one.
I think, one of the like simple things that we do is just trying to consolidate stress across the season. So that means like, if they have an easy day on court, we're not having a hard day, say in the training room or in the weight room. We're making sure they all match up. So if it's a really low day on court, then the weight room and the training room matched at their lower, more recovery based versus things like a high day. You want to make sure you can kind of push those and make those high. That way their training load is what you don't want is like a flat, like monotonous kind of training load throughout the course of the season. You kind of want these like ups and downs, so that you make sure that they're having time to recover. And then I think just, from like a rehabilitation standpoint or like a training room standpoint, being aware of some of like their workload metrics, tracking those, setting limits as we see fit to make sure that they're not overdoing it as they're returning, making sure they're not engaging in like extra workouts so that we're saving like that work for in game, and then also making sure we're testing frequently and we're keeping an eye on where those numbers are, that whatever KPIs we've selected, to make sure they're not dipping a ton as often as we can with a very big road schedule, but making sure we stay on top of those so we have kind of a look under the hood for the athlete. Yeah, I know that was very general, but I'll pass it to Carlos.
No, for sure. You started off great. I think just to expand a little bit on that, I think like Ryan was saying, I think taking a look at the season schedule, like even, when it first comes out, and, whoever it is kind of puts their heads together, usually, someone from performance, someone medical, someone from the coaching staff. And really the goal is to really try and put the players in the best situations possible so that it's promoting, best sleep practices, best nutrition practices, treatment, recovery, weight room, whatever, like you name it, you really want to make sure that you're getting ahead of it, being proactive about, being intentional with promoting some of these low-hanging fruits that, the athletes have available to them.
Awesome. My next question is specifically when returning athletes to competition following injury. How do you utilize objective tests to measure and analyze the effects of fatigue? Are you guys doing like a pre and post court type testing, battery, or anything else to assess how the injured tissue is responding to stress following fatigue?
Yeah, I guess I'll start off. I mean, it starts off, I think, with like preseason baseline testing, because that's really going to give you a marker of, where they are when they're not super fatigued, when they're not, 57 games in. And just kind of continuously tracking. I think I think the team will kind of decide what's important to, the team as far as tracking, but, individually for a certain player, maybe, looking at, I don't know if it's range of motion or is it force plate testing or something that's easily repeatable, so that, it's on a pretty consistent cadence, so that you can kind of see how, like you were mentioning, how that is kind of fluctuating up and down. And I think Ryan said it before, like you're going to see, certain waves and, peaks and valleys. And as long as you're not getting too high, not too low, and it's matching up with, the symptoms or what you're seeing clinically on the table, then, I think you can be okay. But, once something starts kind of, maybe like derailing a little bit, then maybe it's time to kind of investigate and, maybe really check in with the player. I know some of them, and not just, NBA players, but I know a lot of athletes wear some of the what do you call them? Some of the sleep rings, the HRV tracking. You kind of give a little bit more personal insight into, how they're responding to a lot of the stressors. So, yeah.
Yeah, and I think going off of that, just whatever objective test you do, try the hardest thing, and it's like the easiest thing, but the hardest thing to do in the NBA season is just to like stay consistent and to, because of how chaotic the schedule is, if you pick like, hey, we're gonna look at this KPI once a week for the next 6 weeks as we're returning you, like do that, and you got to look ahead and plan ahead and say, okay, technically at the 7 day point, like I'm on the road, so I'm gonna test it on day, 6 before we leave, just so that I'm making sure I'm doing my due diligence to test and not kind of let things get away from an objective test measure. I think always having one thing that is more, I guess, like isolated muscle, like a handheld dynamometer, like something where you're looking at strength, and then one thing that's looking at dynamic, like that's kind of where my brain goes, like some sort of force plate jump, making sure you have at least one of those two. I haven't experimented with force plate tests. That's more, I guess what I'm talking about is looking at fatigue over the whatever the weeks are as we're returning them and comparing that to baseline. But as Cassidy mentioned, there was an article that came out in JOSPT, or a blog, that had, force plate testing pre and post practice, something I haven't experimented with a ton, but something that, I think may be able to provide value. You kind of know like how much someone dips in a practice, and you don't have to test it every practice, but just knowing, I guess, how big an effect their acute fatigue has would be beneficial.
Yeah, we've utilized the pre and post practice for returning from muscle strains just to see if the asymmetry grows again. So giving us insight into like maybe towards the end of practice, they're actually having to utilize their uninvolved side more, or in a more intense scenario like a game, are they losing power? Are they losing force through? Are they losing load tolerance? Is it painful at the end of a fatigued state? So giving us insight into the just overall tolerance of that tissue, I think. So all good insights. Bailey, did you have something to say? I know there's a question in the chat.
Yeah, I was just gonna bring that one up. I know, so good question from the chat. Cassidy, you touched a little bit on this, but all three of you guys, if you have further input. Ben was wondering, in terms of some of the limitations with this article, the range of motion measured is like near maximum range of motion, and that may not be the most applicable to like in-game play and things like that. Do you guys think fatigue would still play into these angle changes if they measured the squat to parallel pre and post, or something that's not, that seems like it's sub-max? Hopefully I'm phrasing that question correctly, Cassidy. I think you already talked a little bit about it, but any thoughts that way?
I mean, my initial thoughts were these guys don't really squat to parallel in a game anyway. This is like if we read like knee angle is 128, that's around probably 50 degrees of knee flexion, which I'd say they probably live in that 60 degrees ish range, especially because this is just a jump shot. This isn't, it didn't go into details the distance away from the basket or anything, so I can't say exactly how much, but they're not having to get into super deep knee, hip, and ankle ranges of motion anyway. So I'd say in terms of face validity of the basketball athlete, this is probably a pretty accurate way to measure or like demonstration of measurements of basketball athletes. And I honestly think that if you had them go deeper than this, it would probably have more of an impact with fatigue, if anything, just because it's novel. We obviously they squat deep to tolerance with us in the weight room, but in terms of on court, so I would imagine that they would have more fatigue, and maybe the impact would be higher in a novel movement pattern, if that answers your question.
Yeah, I think that's great. All right, just for the sake of time, I'm gonna kind of keep us rolling. I'm gonna go back, or I'm gonna try to go back to our contact info here, just in case people have last minute questions that they want to reach out for. I'll leave these two and then the next one. But again, just want to say huge thank you to all of you guys for being on. Carlos, Ryan, Cassidy, Tim, thanks for all of your help and work through this. And to everyone in the chat, thanks for hanging out. I really enjoyed talking about it. So look forward to seeing you guys in the future. But otherwise, I'll let everyone get on with their nights.